As usual at these conferences, the conversations that happen during the day are really moving, and I had two conversations at lunch that I'd just like to share quickly with you. One is that I saw somebody, I usually at the beginning ask people how long ago they were diagnosed, and we start with 1 year and 5 years and 10 years, and then we ask people, you know, to keep standing the longer they've been diagnosed. And so I saw somebody from the very first group I went to, like a month after I was diagnosed in 2005. And he's here, and he was diagnosed in 1998. That's 30 years ago. 88? 88. Okay, Nick, well, you want to stand up and just let everybody applaud you for 1988. Woo! And that, I hope, is very heartwarming to the people who are here for the first time. The other conversation I had was with somebody who's newly diagnosed just a few months ago and traveled quite a ways to get here. One of the things he's discovering is that now that he's in the company of many neuroendocrine expert physicians, that some of the things he's been told may not be true, such as there is no treatment, do nothing, there isn't anything to do. Every one of us in this room knows that that's not the case, and we're here a testament to the fact that there are many treatments and life does go on. And for Nick, who's 1988 diagnosed. So the message to everybody who's new here is there is so much hope. In fact, the change in the research and what NET Research Foundation is doing and the pacing of what's happening, it's moving so quickly now. There's so many reasons to have hope, and every one of us has a reason to be there. So I specifically want to say that to the people who are here for the first time, and maybe we're a little bit scared, that we really have, it's so important to be with a neuroendocrine tumor expert. It makes all the difference in the world, in your outcomes. So thank you for being here. With that, I'll turn it over to Dr. Donahue and the tumor panel, and we're going to start with some Q&A.
We've assembled a really great panel here. It's like a mile long. We have 5 cases from patients to review, and just wanted to show you and have a, not necessarily demonstration, but an actual live conversation about how we talk about these patients in a multidisciplinary tumor board conference, and the different management strategies and our options. I think most of the people on the tumor board have been introduced, but maybe we'll go down the line here. Dr. Lee, it's been about 5 hours, so maybe reintroduce yourself. You need a microphone.
So I'm Dan Lee. I'm a medical oncologist at City of Hope, and I co-direct the neuroendocrine tumor program there.
My name is Sid Padia. I'm an interventional radiologist at UCLA, and I specialize in liver-directed therapy for tumors.
Johannes, Czernin, UCLA, nuclear medicine.
Lisa Bodei, Memorial Sloan Kettering. I'm a nuclear medicine physician and director of targeted radionuclide therapy at Memorial.
John Strosberg from Moffitt Cancer Center in Florida. I treat only neuroendocrine tumors.
Randy Hecht. I'm a medical oncologist, GI medical oncologist at UCLA, and I take care of GI neuroendocrine tumors.
Jonathan Goldman, medical oncologist at UCLA. I do early drug development, phase 1 research, and lung cancer research.
I'm Bache Govian. I'm a liver and fat liver surgeon at UCLA and take care of patients with NET.
Mark Gerges. I'm a surgical oncologist at UCLA and help in pancreatic and gastrointestinal neuroendocrine tumors.
Jane Yanagawa. I'm a thoracic surgeon at UCLA, and I specialize in thoracic oncology.
Okay, great. We're going to start with some questions that you submitted this morning. Josh has put together a word salad with the questions that were asked, and it seemed the most common theme that was asked about was treatment and PRRT, and you can see the other ones that are listed there too. So we're going to move into the question. Okay, FDG status has been mentioned several times. What does this term mean? I think Dr. Czernin may be able to handle this one.
Lisa could do it too. So it's fluorodeoxyglucose. It's a sugar. It's injected into patient for tumor imaging. It's based on the fact that tumors eat a lot of sugar. And so when you inject that, it will distribute in the body of patients in proportion to sugar consumption, and then tumors light up because they consume so much sugar. So it's the FDG PET-CT scan that many of you may have had or heard about. That's what this term refers to.
Next question. What can you tell us about PRRT enhancers for patients who have been determined not to be candidates for PRRT? Dr. Bodei.
At the moment, there are trials exploring some molecules like histone acetylators, but at the moment we don't have great enhancers for somatostatin receptor expression. So unless you have interference from sandostatin or somatulin on the uptake, at the moment we have to rely on what is shown at the NET spot on the gallium scan.
Other than scans, which blood tests and lab work are the most successful in determining if a removed neuroendocrine tumor has spread, particularly new tumors undetectable in scans? How are these markers most effectively used to determine that there is a recurrence? Dr. Hecht.
That's actually an interesting question because I think it also varies from person to person. And I'm really curious with since Dr. Strosberg is next to me, and I think it varies. I tend to just use a chromogranin A and to follow people. Unfortunately, there are no studies that I'm aware of that actually show that finding metastases earlier before that are not detectable on a CT scan actually help patients. We know it drives people crazy following all these markers, whether it's chromogranin A, whether it's pancreastatin, whether it's NET test, any of those. The thing at the end of the day that I think is most important is, one is that can you find something that you can do something about? So a positive blood test just may make you look harder, but it doesn't necessarily, there's nothing to ablate, there's nothing to do liver-directed therapies to. And the second thing, which is probably even more important, because you got to get to that other step, is does it make the patient live longer and feel better, which is what we care about at the end of the day.
No, I mean, I agree 100% with everything you said. Early detection of microscopic disease is probably not that critical. We have no evidence that moving treatment into the couple of millimeter size tumors impacts outcomes. But obviously it's important to also make sure that the scans are done well. So for a CT scan, it should be a 3-phase CT scan. MRI we often do with UVIS contrast. And of course there's a lot of controversy about the role of nuclear imaging like gallium-68 as part of routine surveillance. But yeah, there's a lot of tumor markers out there, and various doctors have different levels of enthusiasm for checking them.
Dr. Bodei.
If I may just translate this clinical setting to the early metastatic setting, I think looking for a biomarker that can demonstrate early presence of disease might be helpful to devise treatment in an adjuvant setting. We know that acting earlier, sooner rather than later, is a much better option for patients. So if we want to devise strategies or therapeutic trials for adjuvant in the adjuvant setting, a good biomarker is really warranted.
Can I just comment on one thing, the word trials? And that right now, since there really isn't any, and that would not be considered standard of care, and I think it'd be really interesting to do trials. I mean, I think it would be fascinating, but I just want to make certain that people realize is that outside of a trial setting, doing something like that would at least I would not recommend.
The one after that, if you're receiving PRRT, does the continued somatostatin injections you receive once a month affect the effectiveness of PRRT? Dr. Bodei.
First thing, because I received some questions at lunch. So sandostatin or lanreotide is perfectly feasible during PRRT. They just have to be intercalated. PRRT first, the day after patients can receive their monthly injection. Does it affect? There are some signals from literature. First thing, in the NET trial, patients on the Lutathera arm received standard dose octreotide. Other signals from literature, the Prelude retrospective trial of lanreotide plus lutetium octreotide show the beneficial effect and the feasibility of this treatment.
Yeah, but the question is not the shot afterwards. The question is the shot a month later. Do you skip that shot? Because on the NET one, they had to be off the sandostatin for six weeks.
But in the setting of the expanded access trial, there was no need to do that because you just have to inject PRRT at the end of the coverage period of the 4 weeks.
Right. So the bottom line, though, is we really don't know whether somatostatin analogs have any competitive inhibition of PRRT uptake, correct?
Certainly not of the uptake, and we see that with scans, both lutetium scans and the gallium scans. But there is also signals that they might have a synergistic effect on the response. So it's not only feasible, but probably a good standard of care option.
So, Dr. Bodei, in your practice, patients who are on lanreotide who are going to receive Lutathera, how do you manage that?
You can administer Lutathera at the end of the 4th week, and if the patient is not heavily symptomatic, the date of the Lutathera injection can be around the 28th day, and then after 1 day, the lanreotide or octreotide can be resumed. Otherwise, the patient, if very symptomatic, can be switched to the subcutaneous injections up to 24 hours prior to the injection, just to cover the period.
That's what we're doing also.
I think, are there more questions? Does lanreotide cause your sugar levels to rise like octreotide or sandostatin? Dr. Hecht.
Drugs are, the question, maybe another question is how different is lanreotide from octreotide? There are some differences in what receptors that it hits, but my personal experience is that any of the somatostatin analogs can cause sometimes your blood sugar to go up.
Okay. Radiation exposure from net spot relative to CT and MRI.
That's one I love. There's absolutely no radiation risk associated with the net spot scan. And it kind of put it into perspective. Think about patients undergo external beam radiation. If orders of magnitude higher radiation doses and consequences are kind of minimal if even existing. CT scan has higher radiation dose than the gallium component. But both of them are homeopathic radiation doses. And the MRI doesn't have any radiation, so.
We get 5 thumbs up, we'll do that one. What is the role of highly touted cannabinoid THC therapy as well as other wellness protocols alongside conventional treatments? Any takers?
I'll say something.
I take it. That was a misunderstanding. So, no, but what I think in this case, no, first of all, in California it's legal, as you know. But That's whatever pleases you, whatever you feel makes you feel better, and I don't see a problem with it.
Well, let me just add to that. So, we all know marijuana is quite effective for treating nausea, treating loss of appetite. There seems to be a meme on the internet that cannabis oil is effective at controlling cancer, and I have no idea where that came from. There's obviously no data to support it in cancer in general, and none in neuroendocrine tumors in particular. So, with respect to that, I think most of these products are certainly harmless, but they lack evidence that they work. So, in most cases, they can be combined with conventional treatments, but most of us, I think, don't have the expertise or training to really provide any specific information about most of these drugs or products.
I will say that Latinx did do is Giovanna, I can't see because I'm blinded here. You did do which I recorded session with someone from UCLA about cannabis and neuroendocrine tumors. That was about 6 months ago? And I think, and which I attended, and so I think most of it was lack of evidence, and so to echo and that should be online on your website if people are interested. But I think the problem is it's been very difficult to do research. What I will say, there are two things that concern me, and this is for the nuclear medicine people, is that I would be concerned about high doses of antioxidants in someone who's getting PRRT. I don't know if that might make it less effective. And so we know that antioxidants, at least in some models, also may increase metastasis. That's cancer in general. And so, and since antioxidants, if they have any effect, might be in prevention of cancer, not in people who have metastatic cancer. And finally, I have had several people, not so much with NET, but with other cancers who have, it's Rick Simpson oil, I think is the one that people see online, and I have yet to see anyone benefit, because I've had a goodly number of patients who insist on being treated or making their own oil. They say, Dr. Jack, please do scans in 2 months, even though I recommend against it when they have effective other therapies, and I have yet to see someone whose scans were not worse. I know that's anecdotal, but about antioxidants, do you guys have any thoughts about that?
I don't have experience with PRRT. I have experience with radioiodine therapy for thyroid cancer and hyperthyroidism. We did some scan studies. I mean, they're not great data, but some studies done in Italy and some done in France show that antioxidant therapy with some kinds of antioxidant might actually protect the normal organs while not lacking effect at the tumor site, but very few data, so it's not highly powered.
Let me just add to the weed. I would think we can say whatever we want about this. There's no evidence that it's dangerous in any way in this context here. So if people find it relaxing, pleasant, and helps their symptoms, I wouldn't see a reason why they shouldn't do it.
Yeah, I think I want to add a little bit in terms of what everyone has said. It's the reason why you do it. If you're doing it for somewhat symptom effect, I agree all of us can say that if it's not otherwise hurting you, then it's okay. But if you're just doing it when there's not necessarily any evidence that it's necessarily going to help you, why do you necessarily need to do that, right? Like a lot of these supplements or vitamins or any additional recreational entities, they're at such high concentrations that your body normally wouldn't take anyway. Okay, so if your normal body doesn't take that, then why do you put your body through it if there's not necessarily enough evidence to say that it's going to necessarily help you?
Okay, I think our cases are going to cover the other two questions. For those who have carcinoid heart disease, how do we find a cardiologist with NET knowledge and experience with carcinoid heart disease? Dr. Lee, you want to take that one?
So that's hard. I think we can all agree that you're right. There's not enough experts specifically focused on carcinoid heart disease. I think the available resources that's available in terms of, Carcinoid Cancer Foundation has a very good website in terms of experts in the field that can be an initial, kind of guidance spot. Obviously, Dr. Zaks in New York is, very prominent in this and everything, and he's actually on one of our patient communication task forces and everything, and he's always, he can point you in terms of the right direction in terms of identifying potentially a local person that might be a partner for you going forward. But if you have carcinoma heart, it is very important for you to find someone that has a little bit more knowledge in this area so that they can really help manage that component of your disease. Like Dr. Strosberg mentioned, it's really a multidisciplinary effort. And I think as medical oncologists, we could all agree that if for someone with significant carcinoma heart disease, we need more help.
Okay, I've been asked that my colleagues hold the microphones closer to their mouths when they talk, or talk louder, because folks are having trouble hearing. Okay, we're going to do one last question, and then we're going to move on to the cases, but that's the first one. As an avid health and fitness enthusiast, it seems to me that there's a disconnect between oncology and naturopathy. The maintenance of healthy blood, bone, tissue, and organs is extremely vital when being treated with PRRT or any chemotherapy. What is being done among professionals to bridge this gap? Loud and clear, Dr. Hecht.
So we try to be evidence-based. It's hard in 2018 where there are alternative facts and there, but basically there is no evidence that naturopathy, I mean, I live in California, and when I moved out here, my dad said that, remember you're moving to California. And so I think that we try to ask questions, and we try to, we try to, give you the best evidence. And in fact, the randomized trials, those graphs that Dr. Strosberg and Dr. Kuntz and all the others have shown, is that's how you ask these questions, which are randomized trials. All the interventions that we have may have have side effects, whether it's PRRT or whether it's everolimus or surgery for that matter. But it doesn't mean that the patients don't do better. And that's what you can try. That's why we're not bleeding people anymore, or using leeches or things like that. So what I would say is that as oncologists, we do take care of the whole patient. I think nutrition is important, but nutrition is not just an excuse to do whatever you find on the internet. And so what I would say is that naturopathy, unfortunately, is BS. Didn't the other person say BS? Can I say that as well?
You can. You can say bullshit, Dr. Hecht.
I think that it's important to take care of the whole patient, and I think that nutrition is important, but I think these are questions actually that we can answer by doing trials. And I think it's really important for the NET community and other cancer communities to actually ask this in a scientific way and ask questions, are there different things we can do from a dietary standpoint to make people feel better and do better?
Yeah, Dr. Goldman, please.
Yeah, just to add on to that, probably we've been looking forward to saying
no,
BS at some point. I think that everyone would understand a patient wanting to do anything possible to help, but I also think that puts patients at risk of being cheated of money and time, and a lot of times I think people consider vitamins, for example, what could be the harm. A lot of the data we have comes from other tumors or cancer in general, but several very large trials in the 90s showed that giving some common vitamins actually increased the cancer recurrence risk, shortened life expectancies, and these aren't multivitamin doses, these were high doses, so I'm not saying you can't take any vitamins, but the idea that you're going to go way off of standard diet and have an anti-cancer benefit is really uncertain. And we should base those decisions on scientific proof. A lot of times we have theories, and those are worth study, but if they haven't been shown to be beneficial, there is also a chance of harm. And I think that's challenging as a patient, because we all understand you want to do anything that could be helpful. But just be aware that there are there are hucksters trying to take your money. There are well-meaning but non-scientific people that don't understand the implications of what they're recommending, and you should be careful. We always think that discussing these possibilities with your doctor is really important. Maybe even a third of my appointments are spent discussing marijuana and other supplements, and so it's an important thing to bring up.
It's great. Well answered. Johannes asked me to explain what a tumor board is. A tumor board is it's a meeting that usually is organized around specific cancer type, where experts pertinent to the treatment of that cancer type from all different disciplines convene and discuss the management of patients and go through cases. So that's what we're going to do now. This is a very confusing thing here. Oh, I see it. All right. Okay. First case, PM. PM is a 51-year-old female who in 2016 was incidentally discovered to have a left lung mass on chest X-ray. Where the heck is this pointer? Here it is. CT scan had a dotatate PET scan that showed the left lower lobe mass. It was 1.3 centimeters and had left paratracheal and hilar nodes in the mediastinum. The biopsy of a lymph node revealed a neuroendocrine tumor. It appeared to be a typical one. So we have a typical primary neuroendocrine tumor of the lung, left lung carcinoid, with metastasis to the mediastinum and left hilum. So I think I'd ask Dr. Yanagawa her thoughts about this patient.
So this patient had, when we first met her, had a small peripheral lung nodule, and that's where we got the diagnosis of the typical carcinoid. And at that point, the discussion was how would we manage that? And usually when I meet with a patient, I go over all the different scenarios. And so one was that we were going to get some sort of staging procedure to see what else could be involved. But in general, for a typical carcinoid that was a small nodule in the periphery of the lung, we would consider resecting that with a surgery. Most of the things that are sort of controversial in that scenario is whether or not the biopsy of it being a typical carcinoid truly reflects what the entire nodule is, because the decision for what kind of surgery to perform really depends on if it's a typical carcinoid or if it's an atypical carcinoid. But a lot of times at the end, when you get the pathology for the entire nodule, it might not be the same as what was shown on the needle biopsy. So we had a discussion about doing a wedge resection, a small resection of the lung, which would be appropriate for a typical carcinoid, versus doing a lobectomy, which would be appropriate if it ended up being more than a typical carcinoid. At that point, we had gotten the staging imaging that showed that she had possible lymph node metastases and did the biopsy that proved the lung metastases. The pathology came back from lymph node. Oh, sorry. But I wanted to
Dr.
go that the
Yanagawa.
main management at that point was to discuss her case at the tumor board.
Okay, so you resected the lesion and the mediastinal lymph nodes.
After we discussed it at the tumor board.
After you discussed the tumor board.
And Tim, maybe it's worth just
Go
discussing.
right ahead.
So the PET scan is somewhat controversial, the utility of a PET scan, but the high FDG uptake, we felt, suggested the possibility of this.
We did both.
We did both. Anyway, we use while there are different considerations of FDG PET, whether a high uptake on FDG can suggest that maybe the biopsy showing typical carcinoid underestimates the aggressive status of the disease.
So even though it was typical on pathology for the biopsies, we decided to perform a lobectomy and mediastinal lymph node dissection because we had a concern that it was potentially a more aggressive carcinoid tumor.
Okay, so you did that, and it came back as a left lower lobe, 1.2 centimeter neuroendocrine tumor, margins negative. Ki-67 was between 2 and 10%, so intermediate grade. There was florid lymphovascular invasion, which lymph nodes were positive at levels 10, 1, and 11. So it was staged at 3A disease, stage 3A. Adjuvant treatment or treatment after surgery for this patient, Dr. Goldman.
It's an area of great controversy in lung neuroendocrine tumors. From one end of we always think about neuroendocrine tumors as a spectrum. From the lower grade spectrum, a small lymph node negative tumor has more than a 95% cure rate with surgery alone. So there's clearly no role for adjuvant treatment. Going to an atypical where there's a higher risk of lymph node disease and recurrence, we do begin to consider it. And then among these tumors where we think the indication is most clear for adjuvant chemotherapy would be an atypical tumor with mediastinal lymph node metastases. Even in that situation, the data is very poor, all retrospective, but most or many of the expert guidelines are to consider adjuvant chemotherapy. The chemotherapy we would use would be what we look at for what we call small cell and even higher grade lung cancer, drugs that are called platinum and etoposide. And while that is our standard practice at UCLA, I would say that nevertheless is controversial and not all would agree. But the course where she was found eventually to have multiple involved lymph nodes did argue, we felt, for platinum-based chemotherapy.
Can you describe?
Just really quickly, we also had a very clear discussion. The degree of benefit is small, but whether or not you get recurrent cancer has a big effect.
Can you describe the difference between typical and atypical lung carcinoids?
Absolutely. So perhaps a little bit different than GI carcinoids, we really depend on the mitoses. So the number of mitoses per 10 high-power fields, and getting a little bit technical here, but the typical or the lowest grade, the least aggressive, and they have under 2 mitoses per 10 high-power fields. It is also true, however, that even these lower risk ones can metastasize. And then this intermediate grade or atypical carcinoids are 2 to 10 mitoses per 10 high power fields. Well, we also have other criteria that we look at, including what we call necrosis, tumor cell death, which is another indication of more quickly growing tumor cells.
Okay, so she recovered from her surgery well. She was given cisplatin and etoposide, as Dr. Goldman said. But a few months later, she developed bad headaches. And you can see the MRI of her brain here, where there was a lesion on the left side and also one on the right side that the arrows are pointing to. So left frontal and right parietal metastatic lesions. I'd ask what you considered for management at this point.
So this was really quite unexpected. It actually came about during the chemotherapy that she was found to have these brain metastases. Really unusual in carcinoids in general. And while we do screen the brain for more typical lung cancers, we don't tend to for carcinoids. The options, thankfully, for treating limited metastases to the brain are actually quite good, with stereotactic radiation, with near no side effects and a very, very high local control rate. We do know, however, that this added to our concern that she would likely have recurrent disease at some point, including the possibility of other brain metastases. At this point that it occurred, we were still giving the adjuvant chemotherapy, so it was perhaps in some ways an easier decision that it just confirmed our feeling that we should go ahead with and complete 4 cycles of adjuvant chemotherapy. So she did both. She got brain stereotactic radiation and chemo.
She did. So that was in 2016. She's recently been imaged and the brain lesions are stable and there's no other evidence of disease. So concluding thoughts about this patient and how frequently you're going to image her or follow her going forward.
It's very gratifying. It's almost 2 years since she completed chemotherapy, really gone back to a full activity level. And I generally image more in the initial period, every 3 to 6 months for a couple of years, and then we'll go to every 6 to 12 months, probably with some imaging ongoing for a long time due to the possibility of late recurrences. I think some of the questions that did come up, some had recommended considering a somatostatin analog as ongoing therapy. I do not think that makes sense in lung neuroendocrine tumors where the evidence for benefit is much weaker. But if any others on the panel had thoughts, that was one of the considerations. And other than that, it's surveillance.
Well, I think one of the things this case illustrates is that lung nets is probably one of the...
Hold that closer, Dr. Strosberg.
Sorry.
Yeah, no, that's okay.
This is one of the areas where we have least data and the highest need for research. So, you know, there's, as you point out, it's this concept of platinum etoposide, even for an atypical.
Closer.
Closer. Is,
Your comments are so insightful, we need to hear them.
So it's really based on no evidence, and also not even much theoretical evidence, because at least in GI nets, you know, platinum etoposide is relatively inactive except for poorly differentiated carcinomas. So we definitely need clinical trials looking at, you know, treatment both of metastatic and adjuvant treatment of lung nets. Also, we don't know the role of adjuvant radiation in this case, because for you know, in non-small cell lung cancer, you'd probably use radiation as well.
Right. That was, thank you for reminding me, that was one of the considerations. The feeling was that she had a complete resection. If there's any gross residual disease or positive margins, we would have felt more indication for radiation, although even that is controversial.
I have a question for the oncologist. So you treat these patients with a hunch that could work, which is good, and it worked. If you now were to monitor whether it works, how would you monitor whether it works, and how would you change it if this treatment hadn't worked?
Well, I have a couple thoughts to that. One is that an alternative way that we could have proceeded, and was discussed with her, was before surgery giving chemotherapy. That does allow you to see if the chemotherapy has some effectiveness, and you can either then do surgery in the middle of chemotherapy or wait till the end of chemotherapy and feel that you've had some evidence for benefit. So that's one way that we consider it. And then your question about surveillance, we have typically done CT scans for surveillance, and obviously there are more sensitive techniques. We've considered some of the points that were brought up earlier, that earlier detection isn't always clearly the most significant of outcomes, but some of the questions have been due to lack of evidence, not doing NetSpot, for example.
Okay, we'll move on to the second case, TB. TB, a 54-year-old gentleman, he presented with a 4-unit gastrointestinal bleed. He had an upper GI intraluminal bleed. They did an endoscopy and they saw gastric varices or dilated veins in his stomach. He then had a CT scan that showed that his splenic vein was clotted and out, which was causing these dilated veins in the stomach. But he had a large mass in the tail of his pancreas, which you can see here, eroding into the spleen. And he also had multiple liver metastases, segments 3, 4B, 5, and 8. All of the liver disease was felt to be resectable with an operation. He had an EUS biopsy of his pancreas. It showed a neuroendocrine tumor. Ki-67 was 20%. Dr. Czernin, would you recommend at this point, in 2018, a dotatate gallium-68 PET for staging 2?
I don't know. Maybe an FDG PET-CT scan.
FDG PET? Maybe we have a little controversy. Dr. Bodei?
I would do both.
Wow.
Because it is not infrequent that these tumors, 20% is still a tumor that is considered, I mean, it's just above the threshold for G3, and it's still a tumor that can be considered for PRRT. In any case, it may very well retain somatostatin receptors, and we need to ascertain the heterogeneity of positivity at FDG PET. It might not be on all the lesions, and this could also guide further imaging, assessments, or treatments.
I agree with Lisa.
I also agree with Lisa.
I think we know this is going to be FDG positive, but knowing the somatostatin receptor expression helps kind of characterize the tumor a little bit better, help us figure out whether it's more well differentiated or poorly differentiated, because 20% is kind of on the cusp. So it's not essential, but I think it would be nice to have a somatostatin receptor imaging study.
So when you looked at when you presented the data before on FDG positive carcinoids and the prognostic implication or response to treatment, you showed that they actually do not respond to treatment. So is that true if they are somatostatin receptor positive and FDG positive, or would they be somatostatin receptor negative and FDG positive?
First thing, FDG positivity is all across the spectrum of neuroendocrine tumors, for example, gastroenteropancreatic neuroendocrine tumors. It's been demonstrated since 2010 that even 40% of G1 neuroendocrine tumors may have FDG positivity. And then, of course, this FDG positivity increases as the tumor is less differentiated, as on the contrary, the gallium dotatate positivity decreases with the less differentiated tumors. Having said that, those data that I presented are pertaining to patients with SST positive, so somatostatin receptor positive tumors that were treated with PRRT. And with the same baseline of somatostatin receptor positive tumors, patients with metabolically active tumors progressed earlier than the other ones. That's what.
Dr. Hecht, maybe think out loud your thought process about the treatment options for this patient.
Well, one question actually that I wanted to actually I had a question first, is that are there findings that you would see on the nuclear medicine that would change what you would do? For example, if you saw widespread lymphadenopathy that lit up on either FDG or dotatate, and that actually might change. The other thing that we often find on dotatate scans are bony metastases, which are not usually seen on cross-sectional imaging. And so, I mean, I agree with you 100% on what you had said, just like Dr. Strosberg, that I think both of them would be useful, mostly in saying, is it worse than it looks on cross-sectional imaging? And then, because I think that would be important to then answer your next question, which is, what would you do with this? And that's a surgical question as well. The patient is having bleeding. He's knocked out a splenic vein, which causes, as Dr. Donahue was saying, is that that goes right by that tumor. I can't really see it from here, but it goes right by that tumor, and therefore, because it's knocked out by the tumor, that the blood pressure is backing up, causing basically like varicose veins, only in the stomach, causing bleeding. So from a surgical standpoint, would resection help with that? I assume that it would, and from portal hypertension.
Dr. Gerges?
Yeah, Dr. Hecht, that's a great question, and I think that's one of the issues, which is something to consider in this patient is the patient, just, regardless of whether all of the lesions are resectable, the patient's having symptoms from the primary lesion.
Right, so I was going to separate those out. So from the primary, taking the primary tumor out would be helpful, because as far as we know, you haven't given the rest that this is a non-functional tumor. The patient's not
non-functional,
hypoglycemic or anything else like
presented
that.
with a bleed.
So therefore, there's a reason to go ahead and take out the primary tumor because of the bleeding, correct? So then the next question is to Dr. Agopian, because this is exactly how we would do in a tumor board, because help with Dr. Donahue run these, and I would turn to Dr. Agopian and say, from your standpoint, how easy it is this, because you only see two slices of this, to at the same time or separately, would you go in and try to take out the rest of the tumor burden? And obviously you'd probably want to know how much extrahepatic, how much disease there is outside. And those are the questions that we would have, and hopefully at the time of Tumor Board, we would, in 2018, we would have that extra information. So Vachi,
Yeah.
what do you think?
Yeah, no, can you guys hear me with this? Yeah, I mean, that's exactly right. This case is challenging for many reasons. Looking at a presentation like this, the fact that the Ki-67 is 20% and there could be some heterogeneity in this tumor, it would make you a little bit nervous just to kind of dive right in and try to address everything at once, just looking at it. I agree with Dr. Gerges that I think that the splenic vein thrombosis is obviously due to a bulky mass compressing and clotting off the splenic vein. So the treatment of that, and regardless, I mean, basically taking out the primary tumor and the spleen, and hence the drainage, would at least deal with his life-threatening gastric variceal bleeding. I think how we would address the liver, again, it's hard for me to say just looking at these 1 or 2 scans. If it was assessed to be resectable, I certainly trust that assessment. I think you'd have to look up and down. It does look like there's a lot of disease in that liver, especially over there, segment 4A, which is kind of the more difficult areas to look. It says segment 4B over here, but I'm sure that goes up. But in general, an assessment of liver resection, I think we have to, the way that we always look about it, especially in this disease process, is how much bang for your buck are you going to get? So meaning how much normal, healthy liver do you have to sacrifice, and how big is the liver resection versus what you're hoping to achieve, And I think that looking just at these 2 slices, it's a little bit hard to say, but the utmost importance is to make sure that we keep the patient safe from the surgical resection point of view, because, you can potentially, if you cut out too much liver, get into a lot of trouble with post-resection liver insufficiency. So some of the final decisions in terms of resectability, assuming this patient went to the operating room, would be what does the healthy normal liver look like, and what does the intraoperative assessment tell us about how safe it would be to remove all these lesions, but yet leave a very functional, viable amount of liver tissue behind. So
may I add to that? Just a brief thing. The other issue is that even if there are other lesions in the liver at the time of surgical intervention, the issue is whether we could get out at least most of it, because even getting out most of it would probably be beneficial in the patient.
So if we take away the question of bleeding and the possibility of urgent surgery, this is definitely not a case that I would take straight to surgery. This is a perfect case for neoadjuvant treatment, meaning treatment before surgery to try to reduce the tumor burden and enable potentially surgery to be much easier. And with a pancreatic primary and a Ki-67 of 20%, this is exactly the kind of tumor that tends to respond to capecitabine temozolomide chemotherapy. It's not a 100% response rate, but it's probably over 50% significant tumor shrinkage. So taking aside the bleeding and whether surgery is urgent, I would definitely recommend chemotherapy prior to.
For how long?
Until maximal response.
Would that be a reason, because this actually comes up, this may actually not be for the audience, this is more sort of inside baseball, but it is, I mean, these kind of, but sometimes we do the surgery for the pancreas at the same time as the liver. You don't have to, there's no law that says that you have to. So then the other question would be, is that should you take out the life-threatening problem, though they have to have 2 surgeries, and then you could go ahead and do something in between. And there may not, once again, not every case fits a phase 3 trial, and that's the problem.
Right. There is a risk, with chemotherapy of the blood counts going low and increasing the risk of bleeding, but definitely you want to consider giving chemotherapy, especially if the bleeding wasn't too severe, if it was just a one-time event.
I think, if I may add one comment, I think also the decision would be based on the whole body staging of the patient. So I assume that a whole body staging with dotatate and or FDG PET-CT has been done, and there's no other site of disease other than the pancreas, spleen, and the liver.
Right.
I would think that the patient is bleeding still.
Yeah, I agree with that.
And I think that the patient who is bleeding doesn't necessarily need a PET scan.
That's correct. I think that the symptomatic control of this is important and needs to be one of the more primary focuses.
Yeah, but you're also like, you know, you guys are also saying like when you're going in, you're resecting the primary because of the bleeding, and then you're thinking about potentially debulking the liver at the same time. You know, with the Ki-67 of 20%, let's say you do an FDG and the FDG is, you know, very bright, and there's probably some tumor heterogeneity, like you're really getting up to, you know, potentially a high-grade tumor. Are you going to debulk on a high-grade tumor?
No, I mean, generally speaking, we would not. I mean, if we knew there was a high-grade component, that would not be something that you would do to debulk the tumor. And I think, look, I mean, I don't know how this case in particular played out. I wasn't involved in this particular case, but I agree. If you're taking a patient urgently to deal with the bleeding, I would not, as a liver surgeon, say, let's deal with all the liver disease at this time. I don't think that we would do that. You know, but if the bleeding had subsided and all the staging was done, and we've had some time on our side to kind of get a sense of what's going on with this, I don't think just the idea of simultaneously dealing with it is not crazy. But again, we have to be assured that this is not a high-grade tumor, that the full staging is done, that we really think we're dealing with a pancreatic primary with liver metastases, and then that decision becomes, you know, you got to make that decision in an informed manner once you have all the available information. If you have to urgently operate on this patient to treat the gastric variceal bleeding from the splenic vein thrombosis, I wouldn't deal with the liver in that setting.
Okay, well, the patient was taken to surgery. He had a distal pancreatectomy, splenectomy, liver resection ×3. They did a ultrasound of the liver and found 3 additional lesions there that were not thought to be resectable because they were deep in the parenchyma, and they did radiofrequency ablation at the same time. The pathology from the pancreas showed a 7.1 centimeter tumor extended into the spleen. Ki-67 was 15%. No lymph nodes involved. It was well differentiated. The liver, there was 1.4, 9.9, and 1.4, wait a minute, and another 2.2 centimeter, that 1.4 is repeated, lesions. 2 margins from the liver were focally positive. What do we do with this patient after surgery now? Dr. Strosberg.
Well, if the patient hasn't had the dotatate scan, well, I guess this is 2015, but I wouldn't want some kind of a nuclear imaging study to try to really figure out what's left behind, and preferably find out what the somatostatin receptor status is. If it was positive and there's still some residual disease, you could start a somatostatin analog just to try to delay progression, because at some point this is going to recur, or you can just observe very closely. I don't think I would recommend any adjuvant chemotherapy at this time. I would, because it's not going to be curative. There's still residual disease, I think, right? Or is it just margins positive?
Margins positive, that's it. Dr. Hecht, any thoughts?
Well, actually, I was sort of thinking about this, and we've talked about Ki-67 not being a perfect, we use 20% as a, it's a round number. It's a relatively arbitrary, there is some arbitrariness to this. Endoscopic ultrasound was done, and, the piece of tissue that you get from endoscopic ultrasound is, it looks like a thread. It's relatively small, because now the Ki-67 red, and it's probably average, because there are probably areas that are higher and areas that are lower, are 15%. I agree 100% with Dr. Strosberg, which is that unless you can see something on scans, or whether it's dotatate, which we did have available from a research standpoint, at least at that time, is that I probably would watch and wait, because at least at this time there's no evidence. Adjuvant means, for those who don't know, adjuvant means in addition to potentially curative surgery, and there's no evidence that adding octreotide or lanreotide in this point makes any difference.
So after he recovered from surgery, 2 months later he had an MRI that showed numerous sub-centimeter liver lesions. Chromogranin was normal.
So this would be a good time to get that somatostatin receptor imaging.
I don't think they got it. I think it's still early. Anyways, so was put on lanreotide. 1 year later, the dominant liver lesion increased in size to about 2 centimeters that I've pointed at there. Chromogranin less than 5. 1 liver lesion on lanreotide 1 year after surgery.
Still no gallium scan.
Well,
we didn't have
I
it.
think if it's just one lesion that's growing, so in this case, you need to advance the therapy, and really the question is whether you want to just focus on that one lesion or you want to do a more whole body treatment. We often, if it's just one lesion that's growing, focus on that lesion. We actually have an abstract recently looking at that, and on average, if we focus just on one lesion, the time until they required additional therapy was over a year. So by doing that, you kind of spare the toxicity of additional whole body treatment. So you could consider surgery just for that lesion, external beam radiation just for that lesion, embolization, just for that lesion. Or you could choose among the number of systemic treatments, which, as we discussed before, include, chemotherapy, CAPTEM, everolimus, Sutent, or PRRT.
Sid, any thoughts or comments?
Yes, so I think there's a lot of potential options if we make the assumption that this is the only visible site of tumor in the patient's body. Dr. Strosberg is saying there's a lot of local options that we can consider before we consider systemic options. It's highly likely, statistically speaking, that this patient will require some kind of systemic therapy at some time in their future. So I would argue as to why start with a systemic option now, save that for when you really need it. And the local treatments that can be done, specifically, I think, Dr. Gopi and Dr. Gerges and I would probably talk about either doing a focal surgical resection, or if they felt that there were too many adhesions or what's known as scar tissue from prior surgery, we would consider a focal either Y90 radioembolization or just a regular embolization just in that one area. By doing that, then you could watch this patient down the line, 3, 6, 12 months down the road. Should this person develop new tumors, let's say outside the liver, then you could consider systemic options or PRT, et cetera.
Another option would be a microwave ablation or radiofrequency ablation.
Yeah. Great. So the patient had microwave ablation of the segments 3 and 5 liver lesions. Repeat imaging 1 month later revealed numerous lesions. They were all increasing in size. Radiofrequency ablation at this point was not felt to help. And finally had a dotatate gallium-68 PET scan, 2016, and the lesions were positive. Thoughts?
And Dr. Donahue, are all the lesions still in the liver?
They're all still in the liver.
And so I think assuming that the liver function is normal and that this patient is relatively functional, in other words, not reasonably active, we have this debate in our UCLA tumor board quite often as to if you're going to offer some kind of local therapy, do you offer a hepatic arterial therapy such as bland embolization or Y90 radioembolization, or do you consider a nuclear medicine therapy such as PRRT? I think there are pros and cons to each approach. And so there is no right answer, but those I think would be two viable options in this case.
If I may add one comment, I think it's a very appropriate point, and I think the personalized patient decision within the tumor board is the only way to do. From a purely nuclear medicine perspective, if we can treat the smallest disease as possible is beneficial for us and in view of the better result. So in some cases, a prior debulking with liver-directed therapy might be beneficial for us in order to get a better response with PRRT.
So, my personal experience with embolization is that at least bland embolization tends to work best in very slow-growing disease, mostly small bowel, metastatic small bowel carcinoid. This kind of relatively aggressive pancreatic neuroendocrine tumor, in my experience, does less well with a standard bland embolization. Maybe radioembolization works better. In any case, in this particular case, I would probably consider more of a systemic treatment. And like we said, there are multiple options. Probably PRRT or CAPTEM chemotherapy would be my two top candidates.
But I think it's a good example for showing how relative this idea of evidence-based medicine is, because we really have no idea what the best approach is here, and you can't have an idea because these studies cannot be done. It's impossible to have enough cases where you really base your management or randomize something or do this. So that's why, the so-called expert opinion or experience is at least as important as this alleged evidence-based medicine that in large sections of medicine doesn't exist.
But this patient will be a candidate for the COMPETE study. So this would be a great opportunity to be able to actually compare to two treatments that are active and figure out which one is best.
When you say you said before, based on your experience, you would do X, Y, and Z for this patient.
Yeah.
And I think you deprive the patient of your experience if you randomize him to something that kind of contradicts your experience. That's why I say data are excellent, but often it is really more important to provide the treatment that you feel is best, or that you know from your experience is best.
I think I have to agree with Dr. Strosberg on this. Maybe this is my medical oncology bias, but I mean, if you look at this patient's case, after you did liver-directed therapy, it's only 1 month later, and there's numerous lesions that have increased in size. So if you keep on doing liver-directed therapy in this patient, you're essentially going to be just chasing. And this is kind of the biology of the disease telling you that somewhat this is a relatively aggressive type of tumor, and that maybe a more systemic approach is probably more indicated.
I absolutely agree with Dr. Strosberg too. My point was actually that one shouldn't always expect to have evidence, but really go by your knowledge and experience.
Just to play devil's advocate in terms of the liver-directed therapy, there are multiple different types of liver-directed therapy. They're not all built the same. So in this person had what's called a microwave ablation, where you put a small needle in, you heat the tissue, but it's made for focal tumors. Now they have multiple, so we would not consider a thermal ablation where you're putting needles in. We would do a more global approach. So the results, both safety, how the tumors work, how people survive from a more global hepatic arterial therapy compared to these focal thermal ablations is entirely different. It's comparing apples to oranges. Similar to saying that, well, chemo didn't work.
Closer.
That chemo didn't work, that means no chemo will work. So that's a similar analogy that I would make.
Okay, we're running a little short on time. So this patient wound up going to Germany to have PRRT.
If I may add one thing.
Sorry.
Whatever you want to do, I mean, if you want to do the liver-directed therapy in consideration of the high progressive rate of the tumor, then you have to intercalate PRRT very closely.
2016, went to Germany, had PRRT. The post-dotatate gallium PET scan was a complete response, and recent imaging 2 years later shows no evidence of disease. So systemic therapy apparently was a good choice and an effective treatment. Okay, we're going to go through one more case, and then we're going to open to questions. TJ, 60-year-old female who presented with rectal pain. They did a transanal resection of what was presumed to be a rectal cyst that was causing the rectal pain, but the pathology showed a 5-centimeter neuroendocrine tumor, positive margins, well-differentiated, Ki-67, 20%. The patient then underwent an abdominoperineal resection where essentially the rectum, the anus, the pelvis are removed. And the pathology there showed 0 out of 16 lymph nodes positive, and the margins were negative. Management of this patient, or surveillance going forward, Dr. Lee.
So resected, relatively high Ki-67 proliferation index, and I assume there's no evidence of disease, right?
Correct.
So, this is where we get back to that imaging question that we had at the beginning of the day for the new patients. So there's not, clear cuts, evidence-based and whatnot. I think for me personally, I would be a little bit concerned about, the high Ki-67 proliferation index. So probably want to watch this patient relatively closely. So would want to most likely get follow-up imaging studies at 3 months after the surgical resection.
What's this patient's risk of recurrence?
Very high.
Yeah.
But the positive margins are particularly concerning.
But now they're negative.
Oh, I didn't see that.
That was not negative. No known disease at this point.
Still high, though.
Still high.
Yeah.
Okay. Well, she was then lost to follow-up for 6 years, but came back with back and abdominal pain in 2016 with multiple liver lesions, Ki-67, 20%. What do we do now? Dr. Hecht, rectal carcinoid, liver metastases.
I think that I would, first of all, can you hear me?
Yeah.
I would restage the patient. This is all that we have. I think a dotatate scan would be very reasonable, which we were doing back in 2016, though, through the expanded access, and so, or through the research program, because I think that would be important for further therapies as well, such as PRRT, as well as seeing whether or not there's disease that really can't be seen on cross-sectional imaging like CT or MRI. I think we were talking about before, bony metastasis in particular is something that we pick up on this. The other thing is that how symptomatic is it? Was just a little bit of abdominal pain and someone did a...
No, she said brought her back after being lost to follow-up for 6 years. She was in pain.
Mm-hmm. And then it's a little bit... There, that's a little bit better. That's more impressive. Now I can see. And so, I mean, but a lot of it depends on, so let's say that the Ki-60, I'm sorry, the dotatate scan only showed liver lesions?
She didn't have a dotatate scan. I think it was...
So let's just say that, but there was nothing else outside the liver?
Nothing else outside the liver on the anatomic imaging, correct.
Okay, so one option would be just to do a somatostatin analog like octreotide or lanreotide alone, because she was never ever on that. I think
talk to them.
She was never actually on that, and so the only thing that concerns me, though, as I said, it's a little bit hard. These are fairly large liver lesions. I also agree with what had been said before about an FGG PET, together with the high Ki-67, and I think that could have been done as well. And it would have made me more concerned about, really about being more aggressive with this. Having the fact that it's been 6 years doesn't, I have no idea. I have one time point as to how rapidly this is growing. This could have been growing relatively slowly over a long period of time. So that's probably what I would do. Was there anything local down in the rectum or down in the pelvis?
No, that's fine. This is her only disease in her liver.
That's probably what I would do, better staging.
So why not use Cape-Tem, or why not use everolimus or Finitor?
Okay, so let's start with Cape-Tem. I'm actually, since Dr. Strosberg is one of the world's experts on this, is that my understanding is that it doesn't work particularly well in rectal cancer patients. Do you want to comment on that? Because people have argued about this.
Yeah, there's almost no information. Primary metastatic rectal neuroendocrine tumors are relatively rare. Anecdotally, I can say that I have not seen great responses with Cap-Tem and rectal nets, but the information is very limited. So I tend not to use it for rectal nets, and certainly not as the first option.
How about a targeted therapy?
And I think it's sort of the same as that. Most of the data is there's not that much data with rectal, and I think that on the other hand, I think I would start, since once again I don't have a great feeling, I only have one data point. All the other medicines that you have, such as everolimus, which you could get, a small molecule VEGF inhibitors do have activity, even though they're not approved, and we've used them before. They have more toxicity, and I would probably do that first. If the patient's having a lot of symptoms, and that's why I was asking before, I would consider some sort of destructive therapies to the liver.
So she was placed on somatostatin and everolimus, but developed bad mouth sores, and she was treated with Moogard. What's Moogard?
It's a very expensive sort of coat. It's a very, the mouth, exactly. It's a very, it's expensive, but it's basically a way to coat the mouth. It's prescription. And generally, I must admit that I don't use it very much. The treatment, if someone is on everolimus and they're having mouth sores, is not necessarily give them Moogard, but to reduce the dose.
Or Decadron mouthwash. I mean, I would say that actually the standard these days is even to do mouthwash, Decadron mouthwash prophylactically. It's a steroid mouthwash, and it's been proven to reduce the mouth sores.
But This is the problem, what I was just saying, which is that you've now committed this person to daily treatments, whether it's with a small molecule VEGF inhibitor or whether it's an mTOR inhibitor which may have toxicity. Because I think one of the important things with these neuroendocrine tumors is that you're playing the long game. Because as Giovanna pointed out, so many patients do well for such a long period of time that you really want to, think about long-term treatment.
So about a year later, the liver, you go right ahead.
One question. Gallium donatate wasn't available at that time, but Octreoscan was. So was it attempted, at least to check that somatostatin had a target?
I don't remember that. I'm not sure, but it should have been. I would assume yes. The year later, the liver tumors were larger and the pain was getting worse. Is this a good time or indication for hepatic artery embolization? Dr. Strosberg.
Yeah, we do a lot of embolizations. My personal experience is that when you have tumors this large, the efficacy is often not as good as if the tumors are a little bit smaller, but certainly it's a reasonable option. And of course, PRRT is a very reasonable option if the receptor status is positive. And I'm curious what Lisa and Johannes have to say, because anecdotally, the several patients with rectal NETs that I've treated have had really exceptionally good responses. I'm wondering whether that's been the trend.
We just had whispered about that. Why? I never understand the timing, and I think that's a question that patients also have. Why are we always so late with PRRT? And why are we doing embolization and these kind of things without doing almost simultaneously systemic treatments?
If I may address that, I think because I've seen the same curve in Europe. When I started doing PRT in 2000, we were getting the end-stage patients. So after several lines of treatments. And then now in Europe, patients get PRT in very early stages. So I assume we will get there too, now that we have an approved tool here in the US. And in answer to what Jonathan was saying, yes, I have the same experience. Rectal neuroendocrine tumors that anecdotically respond exceptionally well to PRT, even the most diffused ones.
Two questions. One is that I think that has been already what we're beginning
to
I think that's what we're already beginning to see, that the patients that we were sending for the expanded access were like fifth line patients, and now it's really slotting into second line in patients who progress on single agent somatostatin analogs like octreotide and lanreotide. My other question, this is actually for the two nuclear medicine people, is that we keep hearing how PRRT works better in smaller tumors, and is there a role, once again, for debulking either with embolization or even to make it even more complicated with radioembolization prior to this, and would that make it work better?
Theoretically, yes, but every treatment works better if another treatment has shrunk the tumor, so you have to start somewhere. I guess the answer lies in the Tumor Board decision and in the feasibility and meaningfulness of a particular treatment. So I agree with Jonathan. I mean, if embolization has a meaningful role in the treatment of the patient, then you can attempt that, and then right after you should go for PRRT, not letting all the cytokines, act and possibly induce a progression of disease.
Dr. Strosberg, I noticed on your talk for mid-gut carcinoids, pancreatic neuroendocrine tumors, and other as second-line therapy, you had PRRT in different position on the height of the ladder. Was that intentional? No. It just it was random. Okay. Microphone.
Oh, sorry.
Yeah,
I
okay.
was just saying on the NCCN guidelines where we were debating whether the position influences how...
I think it does.
Probably does.
Yeah. Okay, Sid, well, I guess you got to defend yourself here.
Okay, so just to give a little bit of background, she lives in California and Los Angeles. She does have Medi-Cal. That kind of handcuffs us a little bit. Medi-Cal is the kind of the public aid option. Medi-Cal is the public aid option in California, and it does handcuff us a little bit in terms of what kind of testing we can do and what kind of therapies we can offer. When she saw me, she was markedly symptomatic. I mean, she had really bad pain. You put your finger on her, kind of above her belly button, right where that tumor was, and she really felt it. She couldn't sit still because it hurt her so much, and she was starting to go on, narcotics, and you can imagine the downstream effects of that. So we had discussed liver-directed therapy. To our knowledge, the tumors were still in her liver only, and she had 3 big ones and maybe, I would say 2 or 3 smaller ones. And my goal was to basically kill off the big ones. And then we just do a wait-and-see approach and see how she tolerates the treatments, and then just to kind of take a step back and take it slow from then on, because my main goal here is to get rid of the big tumors and get her symptoms under control. On the right image, that's an angiogram, so you can see that faint vertical line that's up in the patient's aorta, and we do this with sedation. We numb up the skin at the fold of their leg, so it's essentially completely painless. I know many people in the audience have had this done. That catheter that you can see, that kind of faint black and white catheter, that's about, it's like the size of a spaghetti. And the white lines are the contrast dye that we inject, and the x-rays, and you can see that big ball, that kind of grayish ball is one of the tumors. So in this person who was really slow moving around, you could see she had quite a bit of fatigue. You could see the CT scan on the bottom left, which showed these 3 big tumors. I didn't want to get all 3 at once because I knew that was something that her body was not going to tolerate. So her and I made a plan to space this out. We're going to treat 1 tumor at a time, 2 to 3 months apart. We started in August, and you could see we went after that large one in the top right. That catheter where it's now, we went probably about 3-4 inches further, just right up to it. And we injected small particles to kill it off. And then we did the second one, and we did the third one a few months later.
Okay, in the interest of time, here's the other one.
That's the second one.
Here's the third one. Okay, so I think that brings us up to our current present time. So there's her baseline, and on the right is 3 months after embolization. How do we treat this patient now?
Looks like a good response to me.
Her pain is, I would say, probably about 90% better. She doesn't need any narcotics. She takes the occasional Advil or Aleve.
Systemic therapy or not?
I wouldn't rush to systemic therapy as long as she's responding.
No progression outside another
No.
scans? No.
Correct.
I mean, that would be the only reason to do that, would be if there's progression outside the liver. And hopefully, once again, you're doing the long game with this, and that my hope is that this poor woman ends up getting a long period of benefit from this.
I think the other key thing that she did have, and they're not seen on just this single cut, she had maybe 3 smaller tumors. I left them. They weren't growing. They're not bothering her. They're not causing her symptoms. So we're just holding off on them. We know we can offer something down the future, but I didn't want to go overkill and then find out in 2 years or 4 years or hopefully 10 years that we don't have any options to offer. Same thing, we had considered PRRT. I think that's a great option, but I think if she does develop tumors outside of her liver, that would be certainly, we can kind of save that in our back pocket and give her, now we kind of have a full menu for her down the line, and that was kind of my goal for her.
Okay. One last question. We'll end it off with the most invasive therapy. Dr. Agopian, any potential for liver transplantation for this patient? She was diagnosed, how long ago? 2010.
Well, the traditional indications, we talk about, so this was a rectal neuroendocrine tumor, correct? And
Correct.
She had an abdominal perineal resection. So one of the theoretical concerns, look, the longer the period of time a patient does not have evidence of extrahepatic disease, the better we feel about the possibility of liver transplantation in patients with low or intermediate grade at most tumors to benefit from liver transplantation. The theoretical concern with rectal tumors is that they drain, especially rectal tumors that low, is that they drain primarily into the systemic veins. They go they also go through the, I'm going to get technical, inferior mesenteric vein into the portal circulation to the liver. This is clearly why she's got many liver metastases, but you got to wonder whether or not she doesn't have any microscopic spread through the systemic veins, which would go to the lungs. So technically speaking, these patients, we've had a more difficult time getting through the exception points, because just on another technical note, the way we're even able to approve these patients have normal liver function. So the MELD score is something we use to basically allocate organs in the United States and really worldwide. And a lot of these patients have very normal liver function tests. So they would never even get to the top of the list for a liver transplant without a regional review board of transplant professionals looking at their case and accepting altogether in a consensus that this is somebody who would benefit from a liver transplant. And they would be very wary of approving somebody for a liver transplant who had a very low rectal neuroendocrine tumor with the worry that they would have extrahepatic disease. I think you can make an argument in this case, nothing's 100%. You can say 7 years out of a rectal tumor, she still doesn't have any lung lesions or extrahepatic lesions. You can make a good argument for it, I think, but you're kind of at the mercy of the review board.
Okay, I think we're going to switch it to questions at this point. We're just going to take them one by, We're not going to have any questions. But as Dr. Czernin said, there's so many ways of management approaches. That's because the treatments have become so many more options. And it's great. As you know, we have our tumor board at 7 o'clock in the morning. And it's so interesting. We don't even have to serve coffee for people to come to it, because the discussions are always good. And we help a lot of folks. I would appreciate some discussion of the problem of tumors that are too small to see. Mine have never been seen by anything but the surgeon's eye. 2 years post-bowel resection, I'm still symptomatic. What are the panel's ideas about surveillance in this situation? We'll take that as no ideas.
That's what I was going to say. That's a very hard problem. We like to base our treatments and make our plans based off of objective things that we can see on endoscopy or a CAT scan or a dotatate or something like that, which I imagine you've had recently. So this is a very difficult thing. I will say, just as a caveat, I wouldn't support this for everybody, but there is another test that we rarely do for things like this, which is a diagnostic laparoscopy. That's another test. That's actually a surgery, but it can be used as a test also. It's taken very hesitantly amongst all of the practitioners.
One thing that I would say, and it's because there's so much information that I really don't have, and this is actually to echo something that Dr. Kuntz said earlier.
We'd like it to echo.
I'm sorry, to echo, to not echo. To echo something Dr. Kuntz said earlier. If this is a carcinoid and the patient has very small volume or very miliary disease that's not seen on cross-sectional imaging or dotatate scan, but still has GI symptoms, that not all GI symptoms are due to hormones made by the tumor. And I think that's actually really important, because a lot of our patients may have small bowel overgrowth. They may, depending where the tumor is, they could have diarrhea from bile acids, they can have lots of things. And so just because I'm reading this correctly, that the patient says, I'm still having symptoms, and it's important for that sort of patient to be seen by a multidisciplinary team, which would include the oncologist and perhaps, and in particular, a gastroenterologist, perhaps, that has experience in neuroendocrine tumors.
I think one last thing is that one should also have an idea of how the disease is going, maybe with some more sophisticated tests like the NET test, which could give an idea. And then, of course, within the NET tumor panel, it should be decided whether the symptoms are more related to the neuroendocrine tumor disease or if they are related to, other features like short bowel syndromes or any other of the possible culprits in the carcinoid symptomatology. But I think, we can investigate more, perhaps.
Okay, I think we'll do the one other question that's there for the oncologist. We'll start with Dr. Lee. Patient's been on cytotoxic chemotherapy for 2 years. There's been no progression. But how do you make the decision to stop a patient on chemotherapy with disease present?
For me, it really depends on, one, whether or not you have progression or not, and in this case, you don't. And two, how is the treatment affecting your quality of life? Is your quality of life still well maintained on the treatment with minimal toxicity? And if so, I would continue. When that other question comes up in terms of, should you switch to a more beneficial treatment that is approved? That is dependent on, when I read that question, what is beneficial? Because when you look at the treatments that are FDA approved, that's only beneficial for a subset of patients. It's not 100%. Okay, no therapy is 100%. And for you, if this treatment is still working for you, I wouldn't necessarily consider taking a risk to move to another treatment that is not potentially going to work for you.
Dr. Strosberg, any thoughts about when you would potentially step down and change to lanreotide in this patient?
Well,
2 years at Cape Tem
yeah.
seems like a really long time.
Well,
No.
actually, based on the trial that we're going to hear, results we're going to hear about
Closer,
shortly,
closer.
it's actually about the
Closer.
average time to progression. Sorry,
That's
it's about
good.
the average time to progression. So no, I would not stop to switch to something else, for example, PRRT. But you always have to consider whether to take a break from chemotherapy, and we don't know the answer to that. With most cancers in oncology, we treat until it no longer works. In other words, until the tumors start growing. The challenge we have here is that the duration of response can be so long, and patients can end up being on treatment for more than just a few years. It could start affecting quality of life. And so I'd have a conversation with the patient about potentially taking a break, particularly if they're having problems. I would be more inclined to continue treatment if their tumor was pretty aggressive to start with, if it was high grade, if they had a very high tumor burden. In that case, I would probably recommend that they continue until progression. I've actually had a patient on Cape Tem as long as 10 years. And this was a particular patient who started up with extremely aggressive disease. And every couple of years, one tumor starts growing, and we've managed to tackle it with local regional treatment. But I'm pretty confident that if we were to stop chemotherapy, we would see massive growth of tumors. So patients can tolerate this for a long time, but it's always a challenging decision to decide how long to continue if the disease is stable.
Lisa, Giovanna, should we stop it there?
Yeah, I think maybe one more question and then we can go to a break.
Okay. Carcinoid, can it return after 10 years? Is 5-HIA plasma or urine test considered more accurate?
Well, definitely yes for the first part. We did an analysis of patients with small bowel carcinoids. Almost all had lymph nodes. Most patients with small bowel carcinoids have lymph node involvement, at least at the time of diagnosis. And what we found is that for the first 8 years, there was actually exactly the same rate of recurrence each year. So recurrence after 10 years is actually not that unusual for a low-grade, typical small bowel neuroendocrine tumor. And I don't have enough expertise to answer the second question on plasma versus urine. I think they're both legitimate options. The plasma is obviously easier to do, but I don't know if anyone else has any experience with the plasma.
I just think that all these tests are false positives as well after you're going for 10 years. The only other problem with all of these, of course, is false positives as well, as people go for a long period of time.
Great. Well, thank you very much, colleagues. It was a great discussion, and I think we're going to move on to the next session.